Hello, this online lecture for the course Pathophysiology 2 is going to be discussing COPD, or chronic obstructive pulmonary disease. But before we talk about COPD specifically, we're going to look at what obstructive pulmonary disease is. And so with this slide, I'd like you to follow along and fill in some of these missing areas of information. So what is obstructive pulmonary disease? Well, it's really this umbrella term that describes airway obstruction, so obstruction of the airway that is worse with expiration. So that would be the breathing out of air. So why expiration? Well, there's more force required with expiration, where that is, you're using your accessory muscles of expiration. Really more time is required to expire a given volume of air, and so emptying of the lungs is slowed. At the end of full exhalation or expiration, there is an abnormally high amount of air that can still linger around in the lungs when we're talking about obstructive pulmonary disease. Now, obstructive pulmonary disorders are characterized by infiltration of the lungs by inflammatory cells, with the release of numerous different cytokines that contribute to or lead to this airway damage and mucus production that exists with obstructive pulmonary disorders. Recall that cytokines are chemicals that are released by certain cells of the immune system, and they can have an effect on other cells in the body. So the unifying symptom is dyspnea, or what we know of as shortness of breath, whereas the unifying sign is wheezing. And this is an important distinction here between symptom and sign. Remember that the symptom is what the patient would report that they're feeling, something that's difficult to necessarily measure at that time. So if somebody says, I'm having trouble breathing, or I feel that I have shortness of breath, then that would be a symptom. But the sign would be wheezing, which is something that you can hear as the person is assessing the patient. The two most common types of obstructive pulmonary disease include COPD, which is the majority, well, all of today's lecture, and asthma. Now you may also read other types of obstructive pulmonary disease, and you can just make note of them in brackets, which is bronchiectasis and cystic fibrosis, which were covered in the respiratory lectures. But COPD and asthma are the two most common types. So what does this result in? What is the pathophysiology, what ends up happening? Well, there's going to be this increased workload of breathing, or this increased work of breathing. And so you get this mismatch of the ventilation perfusion ratio. And there's also decreased forced expiratory volume in 1 second. And we'll talk about that a little bit later in today's lecture as well. So once again, what this results in, this obstructive pulmonary disease, is you're getting this increased workload of breathing. There's going to be this mismatch of ventilation perfusion ratio, and there's going to be a decreased forced expiratory volume in 1 second. So that's FEV1, representing forced expiratory volume in 1 second. So we've talked about obstructive pulmonary disease in what I just spoke of, but you'll also hear of restrictive lung disease. So what's the difference between the two? People that have restrictive lung disease, they cannot fully fill their lungs with air. Their lungs are really restricted from fully expanding to allow for the maximum amount of air to be inspired. And those that have restrictive lung disease may be obese, they may have conditions such as scoliosis or amyotrophic lateral sclerosis, which is ALS for short, restricting the ability to fully inspire the amount of air that is considered normal. So then now we're going to focus on COPD, which, as the name suggests, is an obstructive pulmonary disease that is chronic in nature. Let's have a look at the definition of chronic obstructive pulmonary disease. So it is a common preventable, and that's key, that it is preventable, a preventable disease that's characterized by airflow limitation, which we spoke about when we talked about obstructive pulmonary diseases, that is not fully reversible. Okay, so once somebody has it, it cannot be completely reversed to its original, the lungs cannot be completely reversed to their original state, and it's usually progressive, meaning that it usually does get worse. So let's look at prevalence. Prevalence, and you don't need to write down this definition, but prevalence in epidemiology, in case you've forgotten, is the proportion of a particular population that's found to be affected by some sort of condition. So it's really a measure of disease burden when we talk about prevalence. Don't confuse prevalence with incidence, which has to do with the number of new cases of a disease that comes up, and therefore incidence tells us more about disease risk. So here we have about 600,000 Canadians that are affected by COPD. When we look at mortality or death, it's the 5th leading cause of death in men and 4th in women, which is unfortunate considering it is such a preventable disease. Now, when we talk about prevention, well, what do we mean? Well, smoking is the cause of COPD in about 80 to 90% of individuals. So think of it this way. If this current generation stopped smoking, there would be very little, maybe 10% according to these numbers, COPD, since 80 to 90% of it is caused by active smoking. So that's a staggering statistic and something that's pretty incredible to think about. 50% of smokers, okay, so 50% of the people that smoke actually have what's considered subclinical COPD, subclinical relating to or denoting a disease that's not really severe enough to present definitely, or maybe there's not readily observable symptoms. So they're not maybe showing symptoms yet, therefore they're not aware that something's wrong, and so then they're less likely to go see their doctor if they're not experiencing any symptoms. So that's what we're referring to with subclinical. So meaning that if we had a look at 50% of smokers, they probably would have, or they likely would have some damage that's already started within their lungs that could mean that they could end up with full-blown COPD. And so when we talked about lung cancer in Patho 1, and we had spoken about how lung cancer usually doesn't present itself clinically, or at least obviously, to a patient until people are in their 50s and their 60s. And so it's difficult to scare the youth. If you're telling somebody who's a teenager, or even somebody that's like yourself in university, that, well, you're smoking now, when you're 50 or 60, you could end up with lung cancer. And the thought process of many is, well, I don't really care, 50s, 60s, that's a long time from now. That's not even in my realm of thought. And then there's others that say, oh, well, I'll quit before then. I'm only planning on, smoking during the stressful times of my youth, or whatever excuse that people have. But COPD is very similar to lung cancer in that it doesn't usually come on until the 50s or the 60s. So once again, difficult to scare youth about a future that they're not even thinking about. Okay, so just a reminder about the definition of COPD that I mentioned on the previous slide, so you don't need to write this down right now. Just listen to my words. It's this common preventable disease characterized by that limitation in airflow that we said cannot be fully reversed and oftentimes progresses. Now, COPD includes 2 primary phenotypes, thinking back to genetics, that frequently overlap each other. Okay, so phenotype being the set of observable characteristics of an individual resulting from the interaction of your genotype with the environment would be a fairly basic description of what a phenotype is. So the 2 primary phenotypes then of COPD include chronic bronchitis and emphysema. So let's have a look at the definition of chronic bronchitis and emphysema. Chronic bronchitis is hypersecretion, so too much secretion of mucus, producing this productive cough meaning that you're actually producing something when you cough as opposed to a dry cough, that continues for at least 3 months of the year. So these details need to be really met for somebody to be diagnosed with chronic bronchitis. Emphysema, on the other hand, is an abnormal, permanent enlargement of the gas-exchanging airways of the lungs, which are called acini, accompanied by destruction of the alveolar walls without any obvious fibrosis. So what we have here is a situation where we have a reversible condition, that being chronic bronchitis, and emphysema, which is permanent or not reversible. Both chronic bronchitis and emphysema are associated with this enhanced chronic inflammatory response in the airway to noxious chemicals or gases, that being smoking. So let's have a look at the pathogenesis or the steps of the development of COPD, and then we will break some of this down throughout today's lecture. Step 1 is smoking. So making the decision to smoke is the first step in the development of COPD. Of course, exposure to other noxious chemicals or gases can also be step 1, but as we said, 80 to 90% is smoking related. Step 2, we have the development of chronic bronchitis. So somebody, once they're diagnosed with chronic bronchitis, is now on their way to having COPD. And then step 3 is emphysema. So we know that these are the two phenotypes that exist as part of COPD. Step 4 is chronic hypoxemia. Remember that hypo is low, ox is referring to oxygen, and emia is the blood. So this is a chronic state of low oxygen within the blood. And we know all too well now how this is going to impact cells in the body. And then the final step is Cor Pulmonale, which during our heart failure lecture we mentioned that Cor Pulmonale is the abnormal enlargement of the right side of the heart as a result of disease of the lungs. And the example I gave you in class was COPD. And this here is really where you get sufferers that are just gasping for air for the rest of the life that they live with COPD. Let's have a look at statistics here on active smoking. So that means that the person is actually smoking themselves rather than just being exposed to it passively. Now, the Americas, this is an outdated statistics, but much of it still holds true. The Americas comprise the totality of the continents of North and South America. And what we can see here is this is both sexes here. And have a look at the differences that occur in different areas of the world in terms of how much smoking occurs, with Chile being extremely high. When you separate men and women, men still do overall smoke more than women do. Now, every country in the world has smokers, but more, of course, in some than others, and that's a public health issue. Public Health Canada has been very proactive when it comes to this, but there's still a good 20% of smokers, again, more men than women. And it's hard to control because of personal choice, because of the media, because of peer pressure, because of just even the business of cigarettes. So it's a constant battle with that. Canada is the leader in public health, and yet we still have not succeeded in this area in really getting people to understand that smoking is such a bad decision. Risk factors of COPD. We already know tobacco smoke, but it can come in different forms. So cigarette use, of course, pipe, cigarettes, environmental tobacco smoke in passive form as well. But that active smoking is definitely the number one. Occupational dust and chemicals, so vapors, irritants, and fumes that are inhaled on a regular basis. Indoor pollution and outdoor pollution as well. When we talk about indoor pollution, a big consideration is poorly ventilated areas. So if you have somebody who does maybe a lot of cooking and there's a lot of stove cooking and the ventilation is poor, over time this is damaging to the lungs. Factors that affect lung growth during gestation. So when a female is pregnant, if she chooses to smoke herself, there's even thought that extensive use of antibiotics, preterm birth for a baby, or exposure to air pollution, among other things, could predispose that person to lung damage. Factors that affect lung growth during childhood. So if that child is born at a low birth weight, maybe they have chronic respiratory tract infections, childhood asthma, childhood obesity, all can predispose somebody to the development of conditions such as COPD, especially if they have a variety of these risk factors and then they also smoke, they have a greater chance of developing COPD. And then there's just your genetic and epigenetic susceptibilities. So genetic being that you're just born with this genetic predisposition, kind of within your DNA, within your genes. And then the epigenetic susceptibilities. Epigenetic is the study of these heritable changes in gene expression. So it doesn't involve changes in your DNA sequence like genetics involves. What it involves is kind of everything above and beyond genetics that can influence our phenotype. So this is really a change in your phenotype versus a problem with your genotype. What about passive smoking? Passive smoking is the inhalation of smoke. We call it secondhand smoke or environmental tobacco smoke by persons other than the one that's the intended active smoker. And it occurs when tobacco smoke is going to permeate an environment and cause people in that environment to inhale it unintentionally. So if we look at this number here, just to give you an example of passive smoke with children. So when children are exposed to passive smoke, so fairly high percentage shown here, even more than the exposure of adults. And this can set a child up for future problems themselves with their own lungs. It wasn't until the 80s that smoking was actually really banned in public places, even in hospitals, because at the time it wasn't really identified that, well, if I'm smoking, I'm the one affecting myself, not affecting other people. And so that's why on campus where the university and the college has banned any form of smoking on campus grounds, the reason is to protect everybody else. And then finally, if we look at worldwide exposure of passive smoking, now again, 2011, so a bit outdated, but 40% of children are exposed to passive smoke, and less than adults, so we're affecting children more than we are adults. Okay, so now let's look at chronic bronchitis on its own, and then we'll look at emphysema on its own to look at some of the details. Now, we did already look at the definition of these terms, but it's important to remind you that chronic bronchitis involves that hypersecretion of mucus, so excessive mucus forming this chronic productive cough that is going to continue for at least 3 months of the year. This tends to be worse in the winter months, which is probably not surprising to you. So what's involved in chronic bronchitis? Well, here we have the bronchioles that are shown, and then you can see the alveoli at the end. When we talk about chronic bronchitis, we see this inflammation and thickening of the mucous membrane, evident in this image here, all this mucus production. So there's this accumulation of mucus, oftentimes accumulation of even pus, leading to obstruction. So you get overproduction of a substance, it's going to cause a blockage. And then in order to clear that blockage, your reflex is to cough, and then the mucus and the pus comes up with it in that productive cough. So the body is constantly trying to clear the airways just as part of a normal reflex. So you can see the accumulation of mucus. You can see a plug that is formed here blocking airflow. This is representing inflammation of the epithelial tissue, and then a little bit later we're going to talk about hyperinflation of the alveoli that is a common feature, so overinflation of the alveoli that we see with COPD. Now, this productive cough that we talked about, I cannot tell you how many times on a regular basis when I hear somebody cough, whether I'm working with them clinically or not, and they cough, and then the first thing that they say, and I'm talking about people that are smokers, is, oh, it's just a smoker's cough. It's not a big deal. I always have this cough. No, that smoker's cough should be looked at, because if you have this chronic productive cough and you're a smoker, then you may have chronic bronchitis. So it's time to get yourself assessed. Here's a more realistic rather than a drawn image of that mucus accumulation. Okay, emphysema. Reminder of the definition that we get this abnormal permanent enlargement of your gas exchanging airways that we call the acini, and this is accompanied by destruction of the alveolar walls. So if the alveolar walls are destroyed, you can appreciate that if it's the alveolar walls that allow for the diffusion of oxygen and carbon dioxide, that this feature is going to be lost, which is a feature that's necessary for proper body function. And there is no obvious fibrosis present. Pulmonary fibrosis can occur with other conditions such as asbestos exposure, just as an example, but is not common with emphysema. At least not obviously. Okay, so let's have a look now at the different types specifically of emphysema: centroacinar, panacinar, and paraseptal. You can see that term acinar that we've used before. Okay, acinar or acini, acinus, referring to the alveolar sacs where we know that gas exchange happens. So we have three different images I'd like you to focus on. The first one here is representing normal lung tissue. To simplify things, they've just used initials here, but TB represents the terminal bronchioles. Then we have the respiratory bronchioles, and then as we move deeper into the lungs, we end up at the alveolar ducts and then the alveolar sacs. So this is what normal should look like when, for our learning purposes, when we have a look at some abnormal. Image B. This is centroacinar. Okay, so make note that this is centroacinar, and we'll talk about a little bit of the details, but I'd first like you to be aware that centroacinar emphysema occurs commonly in smokers, and people that have states of chronic bronchitis are more likely to develop centroacinar emphysema. So what does that mean? Well, you can really see that excessive dilation or widening of the respiratory bronchioles when you compare to normal. Centroacinar emphysema is the most common type of emphysema, and it tends to spare the alveolar ducts, as you can see, and the alveolar sacs when we compare to normal. But you can really see that there is problems with the respiratory bronchioles, and really think of this as destruction, as we know emphysema is. And I should also state that the surrounding lung tissue is usually also untouched. Okay, now we'll move on to another type of emphysema, and that type is the panacinar. So that's C here. Actually, I'll use a different color, slightly different color. So C then is our panacinar emphysema. And this involves alveolar and the respiratory bronchial walls that are damaged. So we can see that the respiratory bronchioles are affected compared to normal. The alveolar ducts and the alveolar sacs are all affected. So whereas we had this kind of local and focus to the respiratory bronchioles expansion, what we get with the panacenar is this global air expansion, and then there's going to be destruction as well. This is more common in older adults and those with what's called an alpha-1 antitrypsin deficiency. What is alpha-1 antitrypsin itself, and what does it mean if there's a deficiency? Well, before I tell you that, I need to maybe remind you of a term that you've heard of before, which is called proteolysis. Lysis we know is breakdown. Proteo has to do with proteins. So proteolysis then is the breakdown of proteins into smaller polypeptides or amino acids. And this is done then, this process of proteolysis, by enzymes that are called proteolytic enzymes. Alpha-1 antitrypsin is a protein that's normally found within your lungs, but also found within the bloodstream. It acts to inhibit or stop the action of many proteolytic enzymes. Those that have a deficiency in alpha-1 antitrypsin have an increased likelihood of the development of emphysema because, so this is just genetically, because proteolysis in the lung tissue is not inhibited. So protein breakdown occurs when it shouldn't, it's uncontrolled. If you have somebody that develops emphysema before the age of 40, deficiency of alpha-1 antitrypsin is suggested. Or in, let's say, somebody who develops emphysema, but they don't smoke and they haven't been exposed to any chemical toxins that would normally predispose them to the development of emphysema. The final type of emphysema is the paraseptal emphysema, and we won't be talking about this one in detail, but I just want you to be aware that it is very similar to centroacinar, but in a different location. Before we move on, I want to revisit the definition of emphysema, which is the abnormal permanent enlargement of the gas exchange airways. So we can see that abnormal permanent enlargement of the gas exchange airways very clearly in these images, accompanied by, in particular with the panacenar, that destruction of the alveolar walls. We're going to have a look at how smoking can cause emphysema. Emphysema, you will commonly hear this term used interchangeably with COPD. People who smoke are going to have this pretty extensive attraction of inflammatory cells to the lungs. And it makes sense because you're bringing in this toxic substance and the body responds with an inflammatory response as part of our immune reaction. These inflammatory cells are going to release different substances, and we're going to use the example of elastase. So elastase is an enzyme that digests elastin. Elastin is a protein that makes up part of our lungs. Elastase, ACE meaning enzyme, is an example of a proteolytic enzyme, an enzyme that breaks down proteins, in this case, elastin, which I said is a protein. So inflammatory cells release this proteolytic enzyme called elastase. Now, in somebody who has normal amounts of alpha-1 antitrypsin, alpha-1 antitrypsin will inhibit that proteolytic activity of elastase. However, there's another situation, which is that if somebody has an inherited alpha-1 antitrypsin deficiency and they smoke, the elastase is going to be very destructive, leading to destruction of, in this example, the elastic fibers in the lung, leading to emphysema. There's another example here, though, when it comes to smoking, where somebody could have decreased alpha-1 antitrypsin activity. This can occur from a couple of different perspectives. One, those that smoke tend to have reduced alpha-1 antitrypsin activity. And if alpha-1 antitrypsin isn't working properly, then we know that the proteolysis will take over, leading to destruction of the lungs. The release of elastase, though, from these inflammatory cells can overwhelm the normal amount of antitrypsins that are found within our lung tissue. And when that happens, we can also end up with destruction of elastic fibers within the lungs. So we'll look at COPD and this concept of hyperinflation that I introduced earlier. Mucus plugs and narrowed airways, as you'll see, cause this air trapping and hyperinflation upon expiration, because we know that with COPD, it's a problem with expiration. During inspiration, let's have a look at air movement. During inspiration, the airways are pulled open, allowing for gas to move past the obstruction, in this case, the mucus plug, so pulled in. During expiration, we have this decreased elastic recoil of the bronchial walls that have been destroyed really as part of this disease of COPD, resulting in collapse of the airways. So you can see this collapsing occurring in the airways. Remember that expiration is very much an active process where you yourself have to use expiratory muscles to expire. And this collapse of the airways is going to prevent normal expiratory flow. So air can get in, but air can't get out. And when air can't get out, it leads to this hyperinflation of the alveoli, or what we call air trapping. And so people with COPD are dependent really on medications such as bronchodilators, which work to actually dilate the bronchioles to allow for that air to escape. Because again, we know that COPD is an issue with expiration. Individuals that have COPD will naturally start to exhale with pursed lips, and this helps prevent that collapse that can occur with the bronchial walls. I'd said earlier that those that have emphysema, that term is commonly used interchangeably with COPD. It is possible, however, to have COPD and not have emphysema. A person can receive a COPD diagnosis while only having chronic bronchitis, for example. Okay, now we'll look at chronic hypoxemia. At the start of the lecture, I mentioned that people with COPD can end up in a state of chronic hypoxemia. Again, hypoxemia is that reduced oxygenation of your arterial blood caused by some sort of respiratory alteration. And that can lead to hypoxia of tissues where they're not getting enough oxygen that they need for proper function. So why does that happen? Well, we need the walls of the alveoli and the walls of the blood vessels, or the capillaries that exist there as well, to be functioning as they should, to allow for proper diffusion of gases. So this is, here we have an alveolus that's normal and the capillaries that surround it. And if we zoom in, you can see the alveoli here, and you can see a capillary, and what we want is these layers here of the alveoli and of the blood vessel to be suitable to allow for oxygen to do what it can do, which as a gas diffuse into the blood and attach itself to hemoglobin, and then carbon dioxide would leave. And if these walls are damaged, then it's going to be much more difficult for oxygen to leave the alveoli and then travel into the blood. Remember at the very start of today's lecture, I mentioned that obstructive pulmonary disorders can result in a mismatch of ventilation-perfusion ratio. The diffusion of oxygen from the alveoli into the blood is dependent really on two main factors. One is the balance between the amount of air actually getting into the alveoli, which we call ventilation, and the amount of blood that's actually perfusing the capillaries around the alveoli, and that's the Q, or perfusion. So we're dependent on these two main variables, the ability to get air into our lungs to the alveoli, and the ability to actually really get that in to the capillaries. And so I can restate that and say that for gas diffusion to occur, we need good ventilation to the alveoli and good perfusion of blood. So blood coming from really the right side of our heart to our lungs to be oxygenated. Let's look at these images here. Let's look at a normal ventilation perfusion ratio. Here's our pulmonary artery, which we know comes from the right side of the heart, bringing deoxygenated blood to the lungs to be oxygenated. You can see that they surround the alveoli in order to pick up the oxygen that comes in. And then we have the pulmonary vein that takes that newly oxygenated blood to the left side of the heart to become part of the systemic circulation. Let's have a look at low VQ. So a low VQ, there are many instances where this can occur, but in the context of today's lecture, we could say that there is impaired ventilation because of somebody with chronic bronchitis that has a mucus plug that has formed, that has reduced the amount of oxygen that can actually travel and reach the alveoli. And so less oxygen within the alveoli, which means less oxygen gets into the blood, leading to a state of hypoxemia. Now we could go even lower with VQ and say that if there was a complete blockage, then it could cause a collapse of the alveoli where there just is not any airflow getting to the alveoli, again leading to a state of hypoxemia. Now let's look at high VQ. When we are talking about a high VQ, we're saying that there's normal amount of oxygen flow to the alveoli, but it's not getting into the blood. Now this particular image is drawn to show you that if there is, let's say, a pulmonary embolism that's blocking the flow of blood, then this alveoli is not going to have the capillary around it, and so the oxygen in there is really part of alveolar dead space. Nothing can be done with this oxygen to get it into the blood, leading to a state of hypoxemia. But I want you to try to appreciate the fact that if, in cases of emphysema, if the alveolar wall is destroyed, if there's normal oxygen or ventilation reaching the alveoli, if the wall is destroyed, then it can't get into the blood anyways. So ventilation is high, but perfusion is affected. In any case, though, you can see that the common denominator is hypoxemia, a state of low oxygen in the blood, very commonly chronic. And so we have a VQ mismatch that's very common with obstructive pulmonary disorders such as COPD. The graph on this slide shows you what it would look like when the hemoglobin saturation and desaturation is plotted on a graph. This curve is referred to as the oxygen hemoglobin dissociation curve, and it's sort of a bit of an S-shaped curve. Remember, we want oxygen to be bound tightly to red blood cells at the level of the lungs, bringing it back to the heart and then to the rest of the body. And then once it reaches the tissues, we want it to be able to dissociate and leave the red blood cell or leave the hemoglobin and enter the tissue. And so imbalances in this can occur where the dissociation and association isn't where it should be.
Those with COPD tend to be in an acidotic state because of the higher levels of carbon dioxide that are present, what we call hypercapnia. And so we see this shift then, this decreased affinity, this shift of the oxyhemoglobin dissociation curve to the right.
Let's look at the process of going from COPD to right heart failure or cor pulmonale. We know that with COPD, we're going to be in a state of chronic hypoxemia, and I spoke on the last slide about the state of chronic acidosis, shifting that oxyhemoglobin dissociation curve to the right. This can lead to pulmonary artery vasoconstriction. So let's remind ourselves of our pulmonary arteries. So here's a pulmonary artery, and here's a pulmonary artery. And we know that it's the pulmonary arteries that are bringing that deoxygenated blood to the lungs in hopes that it will become oxygenated and then return to the left side of the heart to then become part of the systemic circulation. But if there's lung disease here, events are not going to go as planned. So pulmonary artery vasoconstriction occurs, but why? Well, the process of vasoconstriction of the pulmonary artery has a purpose. It serves to redirect blood flow within the vasculature in the lungs away from the poorly oxygenated parts of the lungs towards the better oxygenated portion of the lungs. So it's really the body trying to balance this VQ ratio initially. So that might be helpful initially down distally, but what's going to be happening now at the level of the pulmonary artery and the pulmonary trunk? Well, it's going to need to, more pressure is going to need to be applied to move the blood now past that vasoconstricted area. So increased pressure then is going to be seen. So increased pulmonary artery pressure is going to be necessary to push the same amount of blood past that vasoconstriction. This is the time, if this is identified as happening, this is when reversal can happen, this pulmonary hypertension. But past this point, once we start seeing changes to the actual heart wall, this is where the disease becomes much more concerning. Now, being under this state without treatment can lead to arterial remodeling. So the arteries remodel to be sort of better suited to this environment of increased pulmonary artery pressure. Fibrosis can be evident within the arteries, and hypertrophy of or enlargement of the smooth muscle layers of the pulmonary arteries can be evident as well, leading to a state of chronic pulmonary hypertension where the arteries that bring blood from the heart to the lungs have become narrowed. They don't allow for the movement of blood properly through it. The right side of the heart here is going to have to work extra hard just to be able to pump blood through what is really almost like sort of an obstruction. And so it in itself will undergo remodeling that we've talked about in the heart failure class, where we see hypertrophy and dilation of the right ventricle, leading to what we know of as right heart failure or cor pulmonale. So remember that when we talk about right-sided heart failure, we're saying that it's the inability of the right ventricle to provide adequate blood flow into the pulmonary circulation at a normal venous pressure, a normal central venous pressure, meaning the pressure required to actually bring blood into the ventricle under a normal pressure. The right ventricle is still unable to properly pump blood into the pulmonary circulation. So we have another confounding variable now where the lungs themselves weren't doing a good job at oxygenating the blood, and now the right ventricle is having a hard time bringing that blood in there to be oxygenated to begin with.
Let's summarize the pathophysiology of COPD. When somebody's exposed to tobacco smoke, it's going to lead to inflammation of the epithelial tissue of the airway, which is going to lead to an immune response where we get infiltration of inflammatory cells such as neutrophils and the release of cytokines, chemicals in the area. This is going to be happening all the time because people that smoke are generally not just smoking once, they're smoking on many different occasions on a regular basis. So there'll be this continuous bronchial irritation and inflammation, which can ultimately lead to chronic bronchitis. Now, neutrophils that are released as part of the inflammatory response will also release themselves proteases or proteolytic enzymes, such as elastase. We talked about elastase earlier as being a protease or proteolytic enzyme that breaks down elastin, which is a protein that is part of the connective tissue within the lungs. And so if we're destroying the support system, the structure of the lungs, then it can end up leading to the development of emphysema. Remember also that some people have inherited alpha-1 antitrypsin deficiency where they aren't able to properly control the amount of proteases that are present, and so the proteases take over and cause destruction of lung tissue. I'd also mentioned that tobacco smoke does reduce the activity in many cases of alpha-1 antitrypsin, even in someone who's not deficient.
And it also, the tobacco smoke and the production of these proteases, as already mentioned, can overwhelm our body's endogenous or that natural anti-protease system that we have in place. So COPD then, we know, is composed of chronic bronchitis and emphysema. And we also know that that's going to lead to airway obstruction, lots of mucus production that can block the airway to varying degrees. Bronchospasms can actually occur usually as part of exacerbations, but this is where the airway actually spasms, so the bronchial smooth muscle spasms, narrowing the airway even further, which can put somebody in sort of an acute state of not being able to breathe properly. Air trapping, we talked about, the hyperinflation of the alveoli. Loss of surface area for gas exchange, well, if the alveolar walls or what we can say is the gas exchange area within the lungs, if those walls are damaged and you're not able to get oxygen through those walls into the blood, and then also not able to get carbon dioxide from the blood into the lungs, then you can see why that's going to be a problem for the body, leading to a reduction in oxygen availability, but also an increase in the amount of carbon dioxide kept in the blood. So really the point there is that even if the ventilation is good and you can get air in, it doesn't mean that your actual gas exchange process is going to occur. So I already mentioned frequent exacerbations can occur, and infections are an important consideration for people that have COPD. And the reason for that is people with COPD have a difficult time clearing their lungs of pathogens such as bacteria, even dust and other pollutants. And you can have, just as an example, bacteria that colonize within the airways and create this infection that is difficult to clear, but it can also do further damage to the lungs. Whereas somebody without COPD, somebody who's healthy, would be able to more likely clear out this dust or other pathogens that they breathe in. So in terms of some of the overall effects of COPD, we've talked about dyspnea or shortness of breath, that persistent chronic cough, oftentimes described as just a smoker's cough. Hypoxemia will result, where chronic hypoxemia, that low oxygen in the blood, which could then lead to hypoxia in tissues. Hypercapnia. The reason for hypercapnia, which is an increase in the amount of carbon dioxide in the blood, is that, again, if the gas exchange surface is poor and we're not able to get that carbon dioxide out of the blood into the lungs so that we can breathe it out as a gas, then it builds up in the blood, and this can lead to that acidotic state that we spoke about earlier. And cor pulmonale, or that right heart failure. And then worst case scenario, then COPD, if uncontrolled, can lead to death. Because unfortunately, some people do still continue to smoke when they have diseases such as this. This slide might be familiar to you from normal anatomy and physiology and learning about the respiratory system and some of the different breathing patterns that exist. Eupnea is a word to describe just normal breathing. But what we're going to look at for a moment is hyperventilation. So we're going to ignore the rest of the breathing patterns for today's lecture. Hyperventilation, described as these rapid, deep respirations. Ultimately, what hyperventilation will do is decrease carbon dioxide levels in the blood. People that have COPD, some people, are prone to hyperventilating, this rapid, deep breathing. When a person hyperventilates, we know that it causes a decrease in the amount of carbon dioxide in the blood, but that might be a little bit delayed in someone with COPD if they're already hypercapnia, experiencing hypercapnia, which is higher levels of carbon dioxide in the blood. But if carbon dioxide levels get too low in the blood, it can lead to some disturbing symptoms for that patient. And so learning how to breathe properly in that current state is very important. One of the at-home remedies includes pursed lip breathing, which I mentioned on an earlier slide, that overall improves ventilation. This really decreases the workload of breathing, improving breathing pattern and promoting relaxation and helping to relieve some of the shortness of breath that can be experienced. We're going to now talk about pulmonary volumes and pulmonary capacities. And this is or should be a review from normal anatomy for you, but it is important for you to understand and fully grasp these concepts for this course as well. So starting with pulmonary volumes, we're talking about volume of air with respect to the lungs. And we have tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume that are all brought into this nice graph tied in nicely together. We're going to start by talking about tidal volume. This is the volume moved in and out of the respiratory tract during normal respiration, so just your normal breathing. So we have inhalation, exhalation, inhalation, exhalation. A way to remember that tidal volume is that if you think of the tide on the beach, tide coming in and out at a fairly regular pace. Now, inspiratory reserve volume is the amount of air that you can inspire above and beyond your tidal volume. So if you're just normal breathing, then all of a sudden you took in a deep breath, that's including now your inspiratory reserve volume. Expiratory reserve volume is the amount that you can breathe out after just normal exhalation, so above and beyond your normal exhalation. You can see here that the expiratory reserve volume is less than your inspiratory reserve volume, and the reason for that is that we cannot fully expire all of the air that's been brought in, which leaves us left with our residual volume, which is just the volume remaining after maximal expiration. On this slide, we're talking now about pulmonary capacities. What is the capacity of our lungs when it comes to how much volume it can take in? And so we're going to start by looking at vital capacity, and then we'll follow by looking at total lung capacity. This is the same image showing you the tidal volume and your reserve and residual volume. On this right side, we can see vital capacity. Vital capacity is really the total amount that you can breathe in and breathe out. So that would include then your tidal volume, the amount you can inspire above that, and the amount you can expire below your tidal volume or outside of your tidal volume. That's our vital capacity. Then we have total lung capacity, and total lung capacity is everything, now including your residual volume. So we can see here then that when we look at our total lung capacity, it is our vital capacity, which is our inspiratory reserve volume, our tidal volume, and our expiratory reserve volume, plus that residual volume, remembering that this is the volume that stays within the respiratory tract that we can't actually breathe out. So a pulmonary capacity is really the sum of two or more of the pulmonary volumes that we spoke about on the previous slide. So how can we measure this? Because clinically it does have importance. We can use a spirometer. A spirometer is a device that measures the volume of gas that the lungs inhale and exhale, and it's usually expressed as a function of time. So how much volume is really moved in a period of time. This is a diagram here of a classic spirometer, or a simple spirometer that's showing you how the volume of air and that's exhaled and inhaled is recorded as this rising and falling line. And spirometers are used for routine assessment of ventilation. So I need to remind you of the definition of vital capacity, which includes your tidal volume, so the normal breathing in and out, and then your inspiratory reserve and expiratory reserve volume, which is the amount you can breathe in and out above and beyond your just normal breathing or your tidal volume. Forced vital capacity is where you can have a patient using a spirometer breathe in, take the deepest breath in possible, and then forcibly exhale as much as they can from the lungs and see what amount of air they're actually able to exhale, because we know that people with conditions such as COPD have trouble with that exhalation, right? And then they end up with the hyperinflation that we talked about. But a great application of spirometry is the forced expiratory volume test, or the FEV. The FEV test can determine the presence of a respiratory obstruction in someone that maybe you suspect has one. And it does this by measuring the volume of air that's expired per second during forced expiration, and then it's expressed then as a percentage, making it really meaningful.
So let's look at how this would look on a graph here. Here's a person breathing in, and then they're told, okay, we need you to breathe out as fast as you can and as hard as you can. And so this is showing you the expiration. And in a normal person, you can see that within the first 1 second, so we call this the FEV1, 83% of air can be exhaled. And that is considered, again, normal. Then, by the end of the second, 94% of the air should be able to be exhaled. Then, by the third second, we should be able to have breathed out 97% of air of the 100% that's expected. So what that means is that by the end of 3 seconds, 97% of the air that you forcibly breathe out should be able to be done within 3 seconds. Now, when it comes to COPD, you can see that this line is quite different. And what we have instead is this struggle with expiration that we know is common with people that have obstructive diseases. So what we can see here is that people with COPD are not able to get out much at all compared to what is normal within the first 1 second of a forced expiratory volume test. And even by the end of 3 seconds and even beyond that, they're still not able to exhale the normal expected amount of air. Really though, any lung obstructions or what we call obstructive pulmonary disease, as we introduced at the start of this lecture, can then lead to this reduced forced expiratory volume compared to normal. So let's have a look at a case study applicable to today's topic. The initial history, we have a 62-year-old female presents to the clinic complaining of dyspnea or shortness of breath that has increased slowly for years. Symptoms she reported have become worse in the recent months, and she's also complaining of this new onset ankle swelling. So we can anticipate that there is edema present. Additional history showed an 80 pack per year smoking history. Remember, we talked about pack years in the recent past. Quit smoking though 5 years ago. No fever or chest pain. Usually brings up a small amount of white sputum in the morning. Denies any weight loss or history of heart disease, tuberculosis, asbestosis, or occupational exposures. Has had occasional bouts of bronchitis in the past, but was treated as an outpatient with antibiotics, and no known allergies or history of asthma. Upon physical examination, as the patient was climbing onto the examination table, they reported that they had some shortness of breath. And we know that that is the unifying symptom of obstructive pulmonary disease. Resting pulse, a bit high, respiratory rate certainly high, and blood pressure still normal. No cyanosis or that bluish tinge that can exist in the skin and mucous membranes. Mild jugular venous distension was evident while sitting, and we talked about this concept in the heart failure lecture. When the right heart fails and blood backs up, it can back up into the venous system, both superiorly and inferior to the heart. And so that jugular venous distension does indicate that the right heart is not doing what it's supposed to do. This patient is using accessory muscles while at rest, so kind of working really hard when it comes to breathing with this prolonged expiration because she can't get the air out that she wants to. And then there's that unifying sign, which is wheezing when it comes to obstructive pulmonary disease. Percussion of the chest was hyperresonant. Now, the lung is filled with primarily air, and so percussion of it should give off resonance. And in the case of hyper or excess resonance, well, this can be heard when there's excess air in the lungs, as we know exists when we talk about that hyperinflation with COPD of the alveoli. And overall decreased breath sounds throughout. She has a palpable liver that goes along with what we talked about with mild venous jugular distension, where that right side of the heart is failing to pump blood out as it should, and you get that backup of blood or congestion of venous blood inferior to the heart and even superior to that as well. 2+ bilateral pitting edema.
remember, or pitting pedal edema. Pedal edema is just the accumulation of fluid in the feet and within the lower legs. And so I'm going to bring up an image to show you what 2+ would mean. Now we know bilateral means on both sides. But in this image here, you can see different degrees of edema, and this would be considered 2+ pitting edema, where you have about 4 millimeters of pitting that exists. And so why does that pitting edema exist in this case? Well, it goes along with the jugular venous distension and the palpable liver, where you have that right heart failing now because of a lung disease such as COPD, where the heart has to work really hard to overcome that pulmonary hypertension that has developed over time. Let's have a look at some diagnostic tests that were performed on this patient. Her hematocrit levels are high. This is a compensation mechanism where the body will produce more red blood cells in order to try to solve the problem of this oxygen deficit that exists in patients with COPD. White blood cell count is in the normal range, so that helps rule out infection. Now looking at the arterial blood, pH of 7.38, the normal range, which needs to be very tightly controlled in the body for normal functions, is between 7.35 and 7.45. If pH is less than 7.35, then acidosis is present. So less than, acidosis is present. If greater than, then alkalosis is present. And once again, tight control of keeping blood pH within this range is very important. And this is achieved by a combination of different blood buffers that on a regular basis work to balance pH. Our respiratory system and our renal system work to also make adjustments to keep our pH within normal ranges. So in this case, with the blood pH still being within normal range, the body is still able to properly compensate for some of the other problems that are going on, which we'll look at next. Because the partial pressure of arterial oxygen is low when we look at normal range, and the partial pressure of arterial carbon dioxide is high when we compare to normal range. So this being hypoxemia and this being hypercapnia. Now, bicarbonate is high in this person, and that's related to the kidneys, which have this ability to either release or reabsorb bicarbonate. And what bicarbonate will do is have the effect of acting as a buffer, and it will help with this state of hypercapnia, buffer the blood to keep that pH within the normal range that it should be. And finally, let's look at the spirometry that was completed on this person. Remember forced vital capacity, so that total amount of expired air. The total volume, she could only remove or exhale 85% total of what was predicted. But remember, what's really important is that FEV1, so the amount that can be expired within 1 second, that is, remember, forced expiration. And she could only expire 45% of what was predicted. And so you can see, as we've already looked at this, the big difference that exists between somebody with COPD with expiration and somebody who is considered normal. All right, well, that is the end of today's lecture. Thank you so much for listening.